So let us say you're running and suddenly your knee buckled. You felt a pop, your knee swelled, and now you're scared. Is it my ACL? Or maybe you've already been told that you have an ACL tear and you might be overwhelmed and wondering what's next. I'm Dr. Sri, I'm a board certified family medicine and sports medicine doctor, and in this video I'm going to discuss what an ACL tear is, how is it diagnosed, what your treatment options really are, so that this way you can make an informed decision about your recovery. So let us first understand about the anatomy of the ACL. So we got a knee model here. So this is the thigh bone called as a femur, and this is the shin bone called as a tibia. The anterior cruciate ligament attaches to the femur and the tibia, and the primary function of the ACL is to prevent forward translation of the tibia in relation to the femur. So basically, let us say if I'm running, I want to make sure that the tibia doesn't move too forward, otherwise it is going to damage the key structures in your knee. So the key structures includes your cartilage that surrounds the bone, and there's also a cushion-shaped structure called as the meniscus that is present on both sides of the knee. It also makes sure that it prevents rotation stability, so make sure that it prevents rotational stability this way. So this way again protecting the key structures inside the knee. It is also important to remember that the ACL alone, which is basically the anterior cruciate ligament alone, does not provide stability to the knee. The muscles surrounding the knee also provide stability, especially the hamstring muscle, which also prevents excessive forward translation. So excessive translation, which is basically excessive movement of the tibia in relation to the femur. So the next question is, can we often suspect an ACL tear without even touching someone's knee? And the answer is often yes. So let us say you're doing a cutting movement like in basketball, and you suddenly change direction, and then you feel a loud pop in your knee accompanied by severe pain and rapid swelling within 1 to 2 hours. It is highly indicative of an ACL injury. Less commonly, some might feel instability but less pain. Another classic scenario, jumping and hyperextending the knee upon landing, again with a pop, pain and swelling. Once I hear the story, I would perform a physical examination to diagnose an ACL tear. If the exam is inconclusive, an MRI will be ordered to confirm the tear and check for any associated damage to your cartilage or meniscus. Understanding another key part of structure, which is the meniscus, is important while we think about ACL tear, as meniscal tears often accompany ACL injuries. So we have two meniscus in our knee. We have the lateral meniscus and then we have the medial meniscus. So these are the blue structures here between the thigh bone, which is the femur, and the shin bone, the tibia. So what the meniscus does is that it acts as a shock absorbing. So basically, if I'm pounding from the top, the force is transmitted in the knee joint, the meniscus absorbs the force and dissipates the force. Imagine throwing a stone in water and seeing the ripples. This is what meniscus does, it spreads the impact. So let us say if someone has a meniscal tear, and the meniscal tear could be a vertical tear, where think about taking a knife and just putting a cut in between, thereby dividing into two halves. Or sometimes what happens is that the meniscus flips off and then gets into the joint, and we call this as a bucket handle meniscal tear. In these scenarios, the meniscus is not functioning properly. When the meniscus is not functioning properly, then the joint forces that come inside the knee, they're not being dissipated, which results in local concentration of the force inside the knee, thereby increasing risk for knee osteoarthritis. It is very hard to predict which meniscus will be involved in an ACL tear. Sometimes it could be a medial meniscal tear, which is basically the inside of the knee, or it could be a lateral meniscal tear, which is the outside of the knee. Unfortunately, once the anterior cruciate ligament is torn, they cannot be fixed. They don't have a good blood supply, so they're not going to heal properly. So the surgical treatment for an ACL tear is basically reconstructing a new ACL. So what the surgeon is going to do is that they're going to take a small graft from a tendon, and the tendon could be a patellar tendon, or it could be a quadriceps tendon, or there's another tendon called as the hamstring that comes and attaches in front of the knee. So they take a small tendon and then they graft into the bone, thereby creating a new ACL. While some newer techniques for direct ACL repair are being explored for very specific types of tears, for most complete ACL injuries, the established surgical approach remains ACL reconstruction. So one thing that is most crucial to understand is that ACL reconstruction alone will not start to provide stability to the knee. As we discussed before, the muscles contribute to the stability as well. So what this means is that without proper dedicated rehabilitation, typically around 6 to 9 months after an ACL reconstruction, the surgical success rate decreases significantly and the risk of re-rupture goes high. Even though that your muscles are not directly injured during the ACL tear, still the ACL tear causes some muscle activation changes and thereby causing weakening of the muscles, thereby increasing the re-rupture risk. This is what physical therapy is designed to address, is to create that muscle activation, thereby decreasing the future risk for an ACL tear again. So the next question is that, is surgery a must? And the answer is, it's not always. A well-known study compared surgical and non-surgical approaches with both groups undergoing physical therapy. So what they found was fascinating. At both 2 and 5 years, general knee function and pain were quite similar in both groups. However, there was one key finding in this study. Almost 50% of the people who selected a non-surgical, so basically who selected that they don't want to undergo surgery, eventually had surgery by the 5-year mark, and that was because they had persistent instability and thereby they were not able to get back to sport. This study is reassuring because it shows that a wait-and-see approach with dedicated physical therapy can be a valid option, especially if your goals don't involve high-level pivoting sports. But it's also important to weigh that against the risk of continued instability. So some studies shows that because one does not opt for surgery, they might have some instability going on, thereby increasing the risk for injuries to the key structures in the knee, such as the cartilage and the meniscus. However, not all studies show though. Some studies actually show the opposite. And one of the reason that the people with ACL reconstruction could also have injuries to the meniscus and cartilage could be due to the fact that the people with ACL reconstruction are able to return to sports sooner and thereby increase risk for further injuries as well. Again, this part of the study is still conflicting. That's why I recommend discussing with your doctor. So based on all the evidence that we have, here's my advice. If you have access to a good surgeon, so for example, I practice in the United States, Lexington, Kentucky, and we have access to really great surgeons. So therefore, the ACL reconstruction remains my primary treatment of choice for all my patients, my athletes. And they are going to couple that with 6 to 9 months of physical therapy so that they can decrease the re-rupture risk. But let us say, if you don't have access to a good surgeon, or let us say, if you don't have enough money for the surgery, in that case, physical therapy can be a viable option. As we have discussed, 50% of patients may not need surgery and they may be able to do activities of daily living without any issues. But there is also a chance that there is another reminder of 50% who may not be able to return back to sport, and that is something that you have to accept. But let us say, if you have access to a good surgeon, but then you cannot commit to 6 to 9 months of physical therapy, then I don't think the surgery is the best treatment plan here. Because without physical therapy, like we addressed before, the re-rupture risk remains really high. So basically, the risk versus benefits of surgery is not being balanced properly here. So one other key point here is that some people with ACL tear will have other concomitant injuries, such as they could have a meniscal tear, they could have a bucket-handle meniscal tear that we talked about, where the meniscus flips into the joint. In these cases, surgery remains the gold standard because we want to repair the meniscus, otherwise the risk for arthritis goes up significantly. Beyond physical aspects, studies have shown that psychological readiness is a key factor when it comes to successful ACL tear recovery. With that in mind, I've created a guided imagery video that will influence your mental strength, thereby promoting a good ACL tear recovery, and you can use that guided imagery video post-surgery. And you will find this video here. If you have any questions or comments, please post in the comment box below. If you found this video helpful, please make sure to hit the like button so this video can reach more people. And I'll see you in the next video. Until then, goodbye.